strategies. Read the question. Anticipate the answer as you read the question. Don't get bogged down in superfluous information in the stem. Eliminate answers that are clearly wrong. When in doubt, the answer with the most information is often right, maybe. More so if it feels crowded, data-ish, or explanation-filled. It's like, oh, they were really trying to make it precise rather than it's just long-winded. Only after reading all the options should you suggest the option you think is correct. So, which of the following patients is most likely to have a decubitus ulcer? An elderly man in a nursing home. Yep, that's it. Check. Okay, we're done. Next question. A patient who suffered severe head injury and has been unconscious for 24 hours. Guy's not moving at all. That's terrible. He's going to get a decubitus ulcer. Yeah, but not in 24 hours. A demented individual is constantly wandering the halls. There's a lot of things can happen to a demented individual who's constantly wandering the halls. A decubitus ulcer is not one of them. A person with severe respiratory disorder who's been bedridden for months. Bing, 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 bing. So, what the answer is, don't just go to something that has part of the answer and read the whole thing and see what's the most correct. You want the most true answer, not just something true. That's why you want to read the whole question carefully with an open mind. Then read and think about all the answers. There are two types of questions that the board forbids and hence API doesn't use, which is all of the following except, or which of the following is not. And the reason they do that is those tests don't discriminate. You know, even super smart people just read them wrong enough at the time that it doesn't tell you who knows the knowledge, it tells you who happened to read the question right. And so would it be good to have doctors reading everything right to make the right decision? Sure. But when you're trying to discriminate medical knowledge, that doesn't work. And then questions with fewer than 5 answer choices don't discriminate well. They can't tell the top people from the bottom people, so you always should have 5 answer choices. So the only time there'd be 4 is if like one of them had to be scratched at the last minute, but they would more likely find somebody to make one up. If you're unsure, guess. There's no penalty for guessing. They don't subtract. If 2 answers are exactly opposite, one or the other is likely correct. Not always, it just increases the chance. We talked about who writes them, so that's folks that get invited to, and then what happens to them. They first go to the ABFM staff that edits them, makes them grammatically correct, and then checks the references and makes sure they're right. Then they go to a group called the Angoff Committee that breaks up into different subgroups so that they aren't influencing each other, and then they score them and they say what percentage of practicing family docs should know this? Is this question worded right? Is it fair? Is the reference correct? And then they see if the two groups agree with each other enough of the time to do that. And then they say, well, should this be only in the module exam or could this be in the general exam? So flag any items that you leave blank as you progress through the test. So I generally think it's better to answer a question and then flag it electronically than to leave it blank. Because one of the things you can do is you could forget to go back and get it. So that way you at least get the guessing percentage. Computer-based flag feature enables you to quickly review unanswered questions later as the test progresses. I used to think the computer exams were terrible. I always wanted written ones, but they're actually getting better, or maybe I'm getting better at it. It's hard to tell. The first thoughtful answer an examinee makes is usually the best answer. So I know this quite well from being the clerkship director in family medicine for a decade because I gave pen and paper exams and I could see who crossed out answers and put in other things. And it's probably like 3-to-1 ratio of changing right answers to wrong as opposed to changing wrong answers to right. So if you think, yeah, that's it, unless you get some really good piece of data like, oh, this is because of that, and I'm sure of it, rather than, well, no, maybe it's this, maybe it's that, 3-to-1. In other words, changing answers usually doesn't increase your score. Don't get tricked by partially correct answers. You need to pick the best answer. Qualifiers such as never, always, and every are typically false. Begin with the end in mind. Which drug is the most likely cause of rhabdomyolysis in this group? Atorvastatin. It's statins. Great, we're done. Oops, simvastatin, higher risk. Remember that they changed the maximum dose from 80 milligrams down to 40 milligrams because it causes higher risk. Gemfibrozole, fibrates, when combined with statins do it, but by themselves don't. Clofibrate, another nasty fibrate, but rhabdomyolysis is not its big thing. And concentrated fish oil capsules, if anything, would probably make it less likely. So you want the most correct answer, so read all the choices. If you just look for a statin, you found atorvastatin and moved on, there would be a lurking simvastatin as a correct answer that would haunt you in the end. Do not try to outguess the item writers. Rely simply on your knowledge to respond to that. So one of my friends who's a very shoot from the hip type of guy, he would say, what would I do? It's like, nothing. And so you think, well, that isn't going to work. So he'd say, well, what would Bob do? So it's like, oh yeah. So somebody who's kind of compulsive, data-driven, but slightly cheap. And so, you don't just want to do every test to be compulsive, but you want to think about most things. So try to find that balance. Think about what good medical practice is. Think what most of your partners do. 24-year-old, 2 days postpartum with severe headache and double vision, equivocal papilledema. What test should they get? CT of the head, lumbar puncture, CT angio of the neck vessels, MRV, observation, no testing. Okay, so it would be debatable. What this person should probably have is an MRV, and that's not really a family medicine question that much because they're likely to have a dural sinus thrombosis, and MRV is better than MRA. CT would be okay, but it's not perfect. You don't want to do an LP until you've done an imaging study, and there's no great reason to do an angio. But this one's just to teach you that sometimes observation and no testing is a good choice. When they're saying, oh, should you spend a bunch of money on this? Should you get a CAT scan or whatever? It's like, a lot of times it's like you've had a stable migraine for 10 years, they're having a couple more, but they've had a lot of stress. Should you get a CAT scan? It's like, no. And so the times when the answer of observation is almost always wrong is during a time when there's serious stuff going on. So like a guy who runs a marathon and has severe chest pain, you should say, oh yeah, he's probably fine, don't worry about it. No. And somebody who's in the postpartum period is in a hypercoagulable state. So they get all sorts of immune phenomenon, all sorts of vascular shifts, all sorts of eclampsia, preeclampsia, post-eclampsia, related HELP syndromes and liver stuff, and they also get a lot of clotting related things, and so they could have a venous clot in their brain. So the point of this was not to differentiate that you need the MRV as opposed to a CT. The point is that there are times and settings when observation might make sense, but during a super high risk critical period when all sorts of serious complications happen, you want to be cheap but not stupid. So consider the worst diagnosis and liability risk. So CT, okay for emergency bleed, but then you want to get the MRV. Don't do a lumbar puncture until you've ruled out herniation, and still it's not indicated because you're mostly looking for clot. CT angio, it might be helpful, but it's not as good as an MRV, which looks at venous stuff. And then the observation. So there have to be better clues if they want you to do nothing. It has to smell like, oh, there's nothing really going on here. I might kind of do that if I had to, but do nothing is a bad choice if it's a high risk with high risk of, and the person has focal symptoms. So strategies, reading the response options first and then finding the correct answer in the preceding material is not recommended. So I've counseled lots of our residents, and one of the other jobs I had at the medical school was to counsel people who were failing all their board exams and flunking out of their clerkships. And so some people got in because they shouldn't have gotten in, but they were in a special group. They said, oh, okay, you can come to medical school. And they went, this isn't really working out. But most of the people I counseled went away and did an MD, PhD, or they said, oh, I'm going to get a law degree. And then they came back and they didn't remember medicine. It's like, okay, you're going to have to get you back in the mode here, folks. So always ensure that you have answered all the items prior to ending the exam. If you leave 20 blank and there are 5 answer choices, the random would give you 20% or 4 more questions right. That could be 30 or 40 points and make the difference between a 390 and a 350. And so you really want to make sure at those margins that just a few extra questions will help you. So trust your office practice instincts. I had somebody who was taking the in-training exam over and over again and flunking it, and I said, just see what you do in clinic, what your partners do in clinic, what the faculty does in clinic, what happens to this patient. Usually, that's what the answer is for most of these things. What would be best for the patient, what's cost-effective, what's safe and standard of care choices. If you think about how you make the decisions in clinic, you'll usually be right. So here's one of my favorite ones. According to the AFFIRM and RACE trials, which one of the following is the correct statement regarding atrial fibrillation treatment? A, rate control leads to better survival outcomes. B, rhythm control leads to better survival outcomes. C, rate control is associated with better cardiovascular outcomes. D, rhythm control is associated with better cardiovascular outcomes. E, rate and rhythm control have similar rates of thromboembolic events. And so cardiologists like talking all these acronyms. Is like even at parties they're still talking about these trials. Well, did you see this and did you see that? So when I read this, I go, the who and the what trial? It's like, I don't know. Maybe I've heard of them, but I don't think I know what they said. So how am I going to figure this out? It's like, okay, well, I know that all the cardiologists, they live there. They live and breathe this stuff. So then I figure out, well, what happens to the patients that I send to cardiologists? Because it must be based on the RACE and the AFFIRM trials if those are based on that. So does everybody I send to cardiology just get rate control? No. Does everybody just get rhythm control? Like, no. Does everybody, if they have their rate controlled alone, is that better for cardiovascular outcomes? I don't think so. Is it rhythm control it's better cardiovascular outcomes? It's like, no. It's like, so sometimes they convert them, and sometimes they just give them rate control. So they must be fairly equivalent. So rate and rhythm control give you essentially the same outcomes. And so I got the result of the AFFIRM and the RACE trial by looking at what my smartest partners and what my referring consultants are doing, even though I don't know that. So just use the data you have from practicing medicine to figure out what the answers are. So think what your cardiologist, your smartest partners are doing. Do they send them for repeated conversion or ablation procedures, or do they do rate control and anticoagulate most of them? They do the latter for most of them.